Thank you very much. And we are lucky to be here for escaping the political hurricane. This is a good hurricane to be in, to be a part of. All right. So.
Maybe that's just David just clicks for us.
Yeah,
Okay.
I'll
So
do
work.
it. Absolutely. Very flexible in the forest.
Yeah.
It's working well.
Goodness me.
Yeah.
Uh-oh.
Technology.
That's a good first slide.
It's a great first slide.
We spent all night on it. You like it?
No one make any blue screen jokes.
Blue screen things.
Not sure why that's happening. For some reason it's playing up again.
Apparently. They didn't tell me on what, so we're just waiting.
Here we go.
We're just winging it.
Okay, we're back in business.
Okay, yeah.
Okay, first slide.
First, thank you very much. So,
You know, I think there's a standard for interoperability.
Yeah,
There is.
yeah.
so our boss is a communications guy who comes up with the standards for 5G and 6G. So unfortunately, he's not here, so that's why.
Just not going to believe it. Doing it again.
I think we have a snowman code for the IR.
Yeah.
Is it max bill?
Well,
Excellent.
between you and you, I think we'll be able to fix it, Don. So.
Don't need
Of course, this
slides.
fails with the IEEE guy.
Of course.
Yeah, of course.
Standard operating procedures. Should go to our national meetings. Those are the best.
Oh, you got a left check.
Can you turn on the fan? I'm serious, you know, this window's turned on. Just push on, I think it's the same setting as this.
That's not going to help with the screen.
And thanks very much to Vinci Rush.
All right, click again.
I
Click
thought
again.
that was going to be a lot more controversial.
Click again.
Oh! You should turn it off. Can you turn the fan on again?
Interpretive dance.
Did you try turning it off and on?
You know, guys, you just wing it and go without the slides.
We could,
could.
but that would be completely boring.
No, don't worry.
No, not necessarily. You can do a dance. Live things up.
See, can you see that?
Thank you.
Others in USBs.
Application.
Yeah, it's just
Don't jiggle the wires.
Maybe it wasn't plugged in all the way.
okay.
Oh! I think there's a defect in the presentation.
Yeah, it's classified.
Corrupt.
Sorry, Chris, it just shorts out every time you want to forward the slide on.
All right, guys, got 5 minutes. Hold that.
We're on to the next session now. Thank you for coming.
For my opening remarks, thank you very much. Maybe just 2 seconds.
Would it be easier just to connect another computer? Oh, there goes the guy.
No, something wrong with slide 3.
Something wrong? No, it's just the whole thing. It's like the HDMI drops, but it's plugged in.
Does it work with the clicker rather than hitting the...
No clicker, it's not plugged in. Yep. That's exactly what
I'll go get Marcus, he might be able to help you. Oh, is he? Okay.
Yeah.
I mean, if it's issue, I can just...
You're back.
This is an application.
Can we try backside the HDMI?
Yeah. Outside the HDMI.
Everyone hands off. Is this only one laptop doing that, or is it?
It's just this one. Yeah.
Oh, okay.
We're just checking if Vince's laptop will work. Yeah, so it's this set.
Probably the graphics card.
Yeah. Sorry, lads.
Well, we need to get that one to work again before then. We need to touch this.
No, this again. What are you plugged into?
That works.
Yeah?
This is mine.
Yeah. So it should be fine. I'll stand in the room while you start, and then if anything goes wrong, give me a shout.
Yeah, we'll just need that one to work for the next guy. So yeah.
No worries.
Okay, in the great tradition of technology, I think we've got a workaround. So I'm just going to reintroduce Raj Gurupur and Vince Lopez, our friends from the States. Very patient friends from the States. Sorry about those technical issues. I'm going to hand over to Raj and Vince now. Thank you.
Thank you guys for being here. We had a little bit of technology storm as well.
Oh,
All right.
Yay.
Okay. Thank you.
It was worth the wait. Yeah.
So a little bit about myself. I have a PhD in computer engineering, master's in computer science. So I have more than 100 peer-reviewed publications, mentored several students in research, work for funded research from NSF, NIH, and other private industry. Over to you, Vince.
Good afternoon. I'm Vince Lopez. I'm the founder and CEO of Parker Health and Parker Health Systems. I'm the chairman and CEO of our federally qualified health centers. So I own and operate federally qualified health centers, primary care facilities in Washington, D.C. and across the United States. Over $50 million in federal contracts and funding we've gotten for NIH programs, specifically in HIV and AIDS, which is in my research world of infectious diseases. I'm the vice chair for ICAD. I have faculty and Dean's Council at NYU, and I am the founder of the Lopez Innovation Hub for Clinical Excellence at NYU in New York. Also have with Raj at UCF for the Center for Decision Support Systems and Forbes 30 under 30 healthcare class of 2023. So last year.
All right, thank you, Vince. Last year we created this ICAD work group for data quality standards for electronic health records. Immediately we got a very good response, like from 54 plus people now. We have from 15 different countries, published 2 white papers, and we meet every month virtually. And we have people from different parts of the healthcare ecosystem. Some of them are nurses, practitioners, physicians, ID people, all sort of, people from the healthcare ecosystem. So our goal is to come up with standards for quality of electronic health records. So that's what we are trying to do. So in the past, I come from, as I said, from an engineering background, moved into healthcare. So in the past, as you all know, medical records were organized in folders and paper folders. And I worked for the Alzheimer's Disease Research Center, where I was a data manager. Used to go to the file cabinet room, pull out the folders, and search for the patient records and put it into the electronic system and all that. So back then, 30 years ago, or even more, was the health information management was a part of library science. Learning how to organize papers and folders in colorimetric, and organize them well so that you can pull out the records of the patients when you need them. So now we all know that now things are all moved electronic. So now it's moved from library system to data science. Now you need computer engineers, you need IT people, you need also mathematicians, all sort of people for to work with the healthcare ecosystems, and you know that better than I do. So, so what we are trying to work on is really define a lot of terms, because there are a lot of things in healthcare information technology that are nebulous, right? If you ask someone what is the difference between an electronic medical record and electronic health record, they probably won't be able to give you a perfect answer. So, what we are trying to do is trying to come up with definite terms for definite, concepts and terminology. So, and then, so far we have defined electronic health records, electronic health record systems, and the completeness of electronic health records. So, our group defined an electronic health record, which is different from an electronic health record system, as data pertaining to an individual's health record available in a suitable electronic form that makes it machine interpretable. So this is our definition for an electronic health record, while we have a much longer definition for electronic health record system. So we have differentiated an electronic health record from an electronic health record system, all right? And the definition for electronic health record system was actually done by a guy named Gary Dickinson. He was one of the founding members of the HL7 electronic health record group. So he's a part of our work group as well. So we're blessed to have him. Now we have Reed Gelser, who's also from HL7. So we have a lot of people from HL7 coming and joining our group, which is a huge blessing. So, Reed came up with a very comprehensive, Dick came up with a Gary came up with a very comprehensive definition for electronic health records. It's real time, it's instantly available, blah, blah, blah. Without getting into the details, I think we'll be happy to share a white paper with you, and you can read it into the details yourself. So this is, continuation of that definition. So it's a very comprehensive definition for electronic health record system. So, as I said, we are trying to get rid of the confusion and the nebulous nature, have definite terms, and then build standards based on those definite terms.
Sounds like an rush. Did you push the arrow?
Yeah. Okay.
There it is.
So
Now
this
it's
is,
continued.
yeah, this is the end of that definition. As you can see, we have so many points listed, so basically we are trying to build these definitions, write these definitions first, and then come up with the standards, because the standards have to be based on definitions, and then finally the incompleteness of electronic health records is defined as a situation where a data element is missing from an electronic health record. Historically, we know that there are three types of incompleteness. There's missing completely at random, there's missing at random, and there's missing not at random. So let me start with missing at random. In missing at random, you have the first name missing because you have the last name missing. So there is some connection. You have one thing missing because the other thing is missing. Now, in missing completely, missing completely at random, there's no connection, right? So there's something missing, and it's not connected, correlated directly to the other variable. Now, what we are really interested in is missing not at random, where there is an observable pattern somewhere, and that pattern is creating a pattern of missingness. So what we did was we built a program that does sentiment analysis of a conversation between a physician and a patient and see how that is correlated to incompleteness of electronic health records. Okay, if the conversation is positive, there could be less missingness, whereas if the conversation is kind of tends to be negative, there could be more missingness. That was the observed pattern in our initial experiment with whatever little data we got from the industry. So we are trying to build these algorithms to see what is missing and why things are missing, because many times it could be because of the administrative processes. There could be bottlenecks in processes that need to be changed, which is beyond an engineer's control. So, so these are some of the things that we are doing. I'll hand it over to Vince from here, and he'll take over the presentation.
Can you click it for me?
Oh, okay.
Thank you. All right, great. So now you got all that. So why does it matter? So this is very much applicable to industry standards. What I will mention, and we didn't mention previously, our PAR has been accepted by IEEE, which means that these standards are now moving forward as we start to move into a full standardized committee, from a work group to a standard committee, and building out the new regulations, if you will, around this. This is important for a couple of reasons. Why? The IEEE is a global industry. It's globally recognized across the board, and so we're going to be able to influence healthcare delivery almost instantaneously. In addition to this, we're working with our colleagues at HL7 as well as ASTM, which is in the US, also the Association for Society of Testing and Materials, who has one of the only federal laws in healthcare, and we'll talk more about that. So we're really bringing in our partners to really move this forward. So everybody always asks me, well, why does anybody care about an EHR? It's boring, it's not important. It is the most critical diagnostic tool in the market today that is the most undervalued and the most underused. Why? Because we don't think about it the way we should. It's a longitudinal health record. It reduces our clinical errors and burnouts. It streamlines communication and access both internally and externally. And it also has a full, complete data set, right, from every level of care that you go through, from primary care to hospice to radiology, labs, etc. Everything is in this system. It's also the practice of evidence-based medicine, which is something that we practice in most medical systems today, except we don't look at any of the data in our EHR because none of it is standardized. None of it is actually feeding into a data set that makes sense. So we obsolete it, or we look into incomplete data sets, which allows us to not be providing the quality services we should be providing. In addition to that, it enables healthcare equity and social determinants of health resources. So all of our famous SDOH rules that we like to look at, we streamline all this by having everything comprehensive in a longitudinal record to deliver the quality of services. And then we unify criteria and regulated standards, much like we do in billing codes, right? ICD-10s, ICD-11s, SNOMED, LIONIC, etc. All of those are standardized globally so that we understand and accept this as a version. What we're going to be able to do with this new standardized model of being a defined electronic health record system and electronic health record, and now we're moving into defining electronic medical record, which will be coming out in the latest white paper towards the end of the year, is really adopt a way that we can deliver care almost universally, but have the same level of communication. And so part of this is you're going to be able to receive an ISO number that's going to be applied to your software and to your technology stack, so that we can understand where there are failures that are happening in all of your technology stacks. Today, for example, in the United States, we have regulation that governs some of this. We have the Office of the National Healthcare Coordinator. The unfortunate thing with that is that they govern and say we're going to certify your EHR based on all of these standards that really are not applicable or followed. And so we're looking at frameworks and things that are of concern. And so we're going to address some of that through our solution. So in the US, we focus on high tech, which is our current governance policy. It focuses on 5 major pieces, what we call meaningful use: improving quality, safety, efficiency, reducing health disparities, engaging patients and families with respect to health care, and then improving care coordination in population and public health, and then ensuring adequate privacy of personal health information. All the same stuff we've been talking about today, some of the same things that we're looking at with openEHR and everywhere else. These are the issues that we're facing at hand, but this is how we're identifying our solution going forward, enabling us to be able to be longitudinally engaged in our health records. As I mentioned, the American Society for Testing and Materials, ES2147, which is the standard for specification of audit disclosure logs for health information. This is an actual federal law that is now governed by ASTM, and part of this allows us to really mitigate how we're using patient data. And if you're familiar with anything in the US, specifically TEFCA and high-tech, the TEFCA Act has actually enabled us to now have master HIE networks in the United States. The unfortunate piece is that some of those data sets are now being sold for, you can guess whatever it's being sold for. So that's where we're at. So part of our standard is to create and enable some of these risks. Go ahead, Raj. And so we identify some of the real world challenges, and these are things that our colleagues and us across the world have worked on and have identified. Standardized data collection and distribution of processes and sets, right? What are we actually collecting? Why is it valuable? Is it meaningful to us, or is it not? Data interoperability, our famous word of interoperability. And then the sovereignty of patient data, cyber attacks and infrastructure security. Some of you guys are familiar with that. The United States had the largest healthcare infrastructure attack last fall with Change Health being hacked. And over 41 million Americans' personal identifiable information was compromised. And so we're looking at those major issues. Our legacy software systems, you're thinking Epics, you're thinking Cerners, Allscripts, etc. Systems that are trying to drive their Tesla with their 1901 Ford engine. It doesn't work, right? And that's where we're in. Third-party risk with integrations and APIs, right? Creating API systems and integration systems that have security in place that matter, right? These are things that we're seeing that are of concern. Limited cloud-based security protocols for PPI and HIPAA data. There's very few systems, major cloud networks, that are not compliant with some of this. In the US, we have standardizations on FedRAMP and all this other nonsense. Again, it checks the box, but it actually doesn't facilitate any of those measures being practiced or followed. And then you have the limited resources and training with professional, clinical, and support staff. So our physicians are not being trained, equipped with the right tools that they need. And then our support staff is also not being equipped with the right support tools that we need. So you call to make an appointment, no one knows how to make an appointment. You call to have a lab result read or pushed or whatever, nobody knows how to do that, right? And so these are real world challenges that I think that we're all facing across the globe. And so what we have provided is our recommended solution. And so this really gets into the work that what we're doing here at IEEE. So we're starting with our problem, again, that we just mentioned, and we're going to go right to solutions. So following internationally accepted frameworks in data collections, openEHR, HL7, FHIR, right? These are frameworks that were there to actually service and give you guidance on what you need to do. The problem is they're frameworks. So there's very little regulations or standards in how you want to use them. And part of what we're doing is enabling that level of governance for us to make sure we're all doing the same thing. Data interoperability. We're interpreting and the adaptability of acceptable internationally recognized frameworks, standard, and regulations. The international standards and regulations would be us, would be HL7, et cetera, openEHR, et cetera. Sovereignty of patient data, following internationally acceptable standards, such as our IEEE work group, right? How are we protecting this data? And we will have a number of white papers and things that we're happy to share with you guys at the end that will give you some more guidance. Our cyber attacks and infrastructure security, so we're looking at utilizing internationally accepted multi-factor authentication and authorization methodologies, and GDPR, GDPR regulation, but also in the US we follow NIST standards, which is all of our security measures around protecting data. And then legacy software, the redevelopment and deployment integration of acceptable internationally recognized frameworks and standards, regs, and all the way down, we go back down to our education, and this really begins in our academic programs, making sure people are engaged. And then basically what we're saying is that we are the new international standard and governing body for metadata associated with electronic health records going forward. We will be publishing more white papers and presenting before Congress and some other folks in the coming months. And so once we get past whoever is going to be our president after today, and who will be leading Congress after today, we will know what will be happening. But we are now being adopted in the United States as the new standard as going forward, as we've now put in place the new definitions of EHRs and EMRs. Thank you. Questions?
Hi, so you're positioning openEHR and FHIR and speaking with an American accent, it seems to be slightly provocative, especially this side of the Atlantic. So what's your reception been to this message so far to non-categorians?
Which part?
To actually put in openEHR and FHIR, together as being options to, for the solution of structured data.
So there's a couple of things. So it's more of a recommendation in terms of what is available that's adopted globally, right? Doesn't mean we're saying you have to use it, but it's where you accept it, right? So whether you choose to partake in using it or not using it, it's one way or the other. But I think globally we're all using it in some capacity at the moment. And much like our colleague from SNOMED said, we have to figure out how to work together. So, somebody else had a question? Yes?
How can openEHR help?
Yes. So, Raj.
Okay, so I think, as Vin said, we are kind of complementing each other. So I think openEHR has a lot of connections in European countries and Australia. So we want to work with openEHR in letting your people know that this is what we have come up with, and again, we are doing something that is unique, and we're building the metadata standards so that help everybody. So so openEHR is great help. Thank you for having us, and we just want to get connected with your people.
I think to add on to that, we've actually invited some of your members to join our work group and now standard committee. So we'll be doing some cross-pollination, I'm sure, internally here as well with what we're working on. So, yes.
So you mentioned data sovereignty.
Yes.
Right after talking about the largest cyber attack, which was a domestic attack, and right before talking about cybersecurity standards.
Yep.
Given that context, is data sovereignty really helpful or relevant for us going forward?
Yes. So, I mean, legally in the United States, we have requirements that protect patients, right? Beyond HIPAA. Everyone's familiar with HIPAA, of course, or PPI standards, but we have other regulations that protect patients and individuals from using any type of technology. So sovereignty of data is very important, as I'm sure it's important here and elsewhere in the world. The biggest thing that we have to look at is how we're actually using cybersecurity standards, which we lack clearly across the world. And so we really need to think about where we're engaging those standards. One of the recommendations I made was NIST, and US NIST standards lay out all of the standardizations we have to have for standard security protocols. But in addition to that, there needs to be comprehensive data sets for healthcare that needs to be addressed. And that's part of what we're starting to get into long term. So when you talk about sovereignty of data, it's a conversation between us, the government, and then the citizens to have that dialogue to determine what's applicable and what's not applicable. And a lot of that is in the US, we're starting to see some of this backfire now, where, for example, I mentioned our Qualified Health Information Networks, the QHINs, which are all independent entities. Basically, they're large data lakes, and you purchase in to be a participant of the data lake. Starts at $30,000 or more, and then those data lakes are actually owned by Epic and Cerner and all the major health insurers. And what they're doing is, once you buy in and all this data is going in, they're actually taking that data internally and utilizing it against the people, raising insurance premiums, lowering access to certain programs. And so these are concerns that we raise, and as opposed to us creating all of these other loopholes, we need to create better standards to protect the citizens from having access to their data. So, somebody else had a question here. I saw a hand. Yeah.
I was just going to ask whether is IEEE thinking of actually writing new standards or trying to do some sort of profiling of existing standards or adding standards maybe in this security area? Like, what's the shape of the output of the program?
Yeah, so this is phase one. So we've got the initial part that's been approved by the standards committee to move forward. And what's going to happen now is we have to work internally with our current other standard groups that are doing cyber, that are doing healthcare, anything in that capacity, health sciences, which is a whole different committee. And we're going to come together and create something comprehensive. But in addition to that, we need all of our other partners, right? FHIR, openEHR, et cetera, to come to the table and have these dialogues. As I mentioned in the presentation, ASTM, which is the group that has the ES 2147, which is for data logging and data auditing for healthcare, they're now going to be involved because that is a federal regulation. It's actually adopted in our CARE Act and our HITECH Act. And so these are going to be conversations now where we're really going to be developing legislation that is going to be able to enact certain protocols. And I think that can be adopted or mirrored globally if you really look at it. So specifically with GDPR. So there's a lot of things that we're mirroring already in the US, but particularly with what we're working on at the IEEE. So, time. Yes. One more?
Yeah,
Okay,
got one
you.
more question.
One
That's
more.
fine.
Thanks.
Yeah.
Have you already looked at what IHE is doing, integrating the healthcare enterprise?
Yes, I have. Raj, have you?
The ISE?
IHE.
IHE.
No, I'm not. My hope is that we are not. We are only doing complementing what they're doing, and we are hoping that we are not reinventing the wheel.
Yes. No, I think we're complementing what IHE is doing. So the U.S., we're coming from a U.S. perspective, so it's a very different process, right? We have a lot of amendments and rights that everyone likes to brag about, but no one really understands what they mean. And so that's our problem. But we're working on that, and I think where you're going, so my background, Parker Health, we're the most comprehensive electronic health record in the U.S. So we're working with the VA and other folks as well. But I wrote the technology stack for it, and this is what we're working on to mirror what we need to see across the country, but globally is what we need to adopt certain metrics. We'll talk off record because I'm getting timed out, but there's a number of other things we're working on that are outside of IEEE that I think would be complementary as well. Thank you.
Thanks very much.
Appreciate it.
Thanks, Raj. And thanks very much again.